Thank you.
I am going to turn the time over to you, give your little introduction thing, and then we will introduce, we'll go around the room so that you know who you're talking to. So, so if you want to introduce yourselves a little bit, and then we'll go around so that you know who's here.
Okay, so I'm Shara. I'm a hospice pharmacist. I own Mountain Care Pharmacy, and I'm just here to hopefully help give you a little bit of extra knowledge that you don't already know about dyspnea and pain management, opioid pain management. I have included pretty much all the information that I'm going to cover today in the handout so that you'll have it for later for reference if you need to, and for the people that couldn't be here. Yeah, thanks for having me here, and glad to meet you all. So.
I call Shara all the time. So she bought from Jared. Jared was the guy that I worked with in Salt Lake, and he actually, the agency I was with was owned by his brother, and we were his guinea pig, and so know Jared, the previous owner, very well. And so Mountain Care has always been, it's been a great pharmacy to work for. So let's start over here, and so again, tell name and what you do.
Jen and
so, one of our case managers. So, Joe?
I'm Joe Crocker. I'm from Physicians.
So he's our medical director. Okay.
I'm Bill Clark. I'm the chaplain and her boss.
Excellent.
I told him to say that today.
Sounds right.
I'm Cammy. I'm just a pharmacist at Shopco, so I have to.
Oh, okay.
So she's not just the pharmacist, she also is the main pharmacist at Shopco. And so she was gracious enough to come and visit with us so that we could let her know too what we do different.
I'm Dusty. I'm Ryan.
Nice to meet you all.
And then Mel had to leave?
Yeah.
Okay. So.
And I'm Faith Calkins. I'm the compliance officer, building manager, lady of many hats at Mountain Care.
So she's our gal, knows our policies and whatever she says that part of it. And so, so thank you. So we are missing a few. So
That's
Melissa
okay.
was here, but she had to run out and see somebody. She was a nurse practitioner. Monica, I told you, is also a nurse practitioner and does case management for us, but couldn't be here. And then Yvonne had some dental work that she had to get done. She'd much sooner be here, but she couldn't make it back in time. So. That's our team here as far as the main clinicians, and then we have 2 nurses and a nurse practitioner in Blackfoot that we'll share this information with. Excellent. And so that's where we're at. So these guys are recording this, so if you have a question, they want questions, but speak up so that we can make sure it's picked up on the recording, and that will be available for our future use.
Definitely.
So, all right, Shar.
Okay, I will jump right in. So I'm just going to cover dyspnea today, and I'm going to focus on nebulization options for treatment. And there's a lot of inhalers out there, obviously, but I've chosen to cover nebulization because it offers some treatment advantages in hospice patients. As all of you know, dyspnea is the perception of an inability to breathe, otherwise known as air hunger. It's often accompanied by fatigue, cough, anxiety, and even pain. Common symptom in hospice patient, often associated with pulmonary fibrosis, COPD, asthma, and often just end-of-life symptom. There's 3 basic abnormalities in dyspnea. The first one's an increased respiratory effort that's required to overcome a certain load or resistance that's seen in the restrictive or obstructive lung disease, pleural effusion, or excessive pulmonary secretions. Increased proportion of respiratory muscle that's required to maintain a normal workload, such as in neuromuscular weakness or cachexia. And then lastly, increased ventilator requirements, like hypoxemia, hypercapnia, metabolic acidosis, and anemia. So the body has an increased need for oxygen, which puts a higher workload on the lungs. Assessment relies heavily off of patient and caregiver report, as well as signs of agitation. Oftentimes we look to oxygen saturations and things like that as an assessment of dyspnea, but it's actually not a very reliable indicator, as you can have normal oxygen saturations in a person who's severely dyspneic. So treatment, if you want to go ahead and change the slide there.
The next one?
Please. So nebulization may be preferred to inhalers in hospice patients because there's a decrease in the, or an inadequate peak inflammatory flow in hospice patients. The key factors that limit peak inflammatory flow are advanced age, female gender, and exacerbation. So exacerbating, an exacerbation of COPD or asthma, that type of thing. It can also have an added benefit that it's a cost-effective advantage over expensive inhalers in hospice patients. So we can use nebulizations. Not only are they going to work better in a lot of cases for the patients, but they're also less expensive. Some of these options include, if you want to go ahead and change the slide again, they include bronchodilators, corticosteroids, opioids, and others. And then one more time. Bronchodilators include beta-2 agonists, anticholinergics, and corticosteroids. Beta-2 agonists are, albuterol, levoalbuterol, anticholinergics such as atropium, and corticosteroids such as dexamethasone or budesonide. They relax the smooth muscle tissue around airways to open up the lungs, and they may relieve spasm of the small airways and provide additional relief. There are short-acting and long-acting agents available. The long-acting agents are Brovana and Performist, primary, and but the short-acting obviously offer a higher cost advantage. They're cheaper. Corticosteroids is the second, and such as the dexamethasone, which we draw up into unit doses in a sterile environment, which is cheaper than the manufactured available budesonide. Obviously, it's kind of an off-label use for an injectable drug, but seems to have a very similar therapeutically.
And we do have 3 or 4 patients now that are doing that. Dexamethasone.
Yeah.
Interesting.
And has been effective.
Yeah. So in addition to relaxation of the smooth muscles, steroids have a local effect, anti-inflammatory effect on those tissues, which can provide an enhanced benefit over the beta-2 agonists alone. It is recommended they use cautiously, as they can cause muscular weakness, which can involve the diaphragm and chest wall. However, nebulization of those medications decreases the risk for that side effect. So it's preferred that they be nebulized to avoid that if you're, are of some concern that the patient that's already compromised, in other words. Particularly effective in treating dyspnea that's associated with, lung cancer or superior vena cava syndrome, tracheal obstruction, or even bronchospasm with asthma and COPD. The next is opioids.
Quick question on the dex. What dose are you using? You said you got them up in dexamethasone nebulized?
Anywhere from 1 to 4 milligrams.
Okay.
We usually base that starting dose off of the severity of the symptoms and sometimes the diagnosis.
Okay.
So if you have somebody with like pulmonary fibrosis where penetration into the lung tissues may be a little more difficult than another patient, we usually start a little higher. So opioids include morphine, fentanyl, hydromorphone. The 2 most common ones we use are morphine and fentanyl. And the morphine can cause bronchospasm in patients, in some patients, and in those cases, fentanyl is preferred. And so just something to keep in mind if you notice that seems to trigger it or whatever, you can switch to fentanyl. Cost-wise, they're both about the same. Hydromorphone's used a little less often, but not for any particular reason. So. And obviously these medications are also effective for shortness of breath when they're used orally, but nebulization again offers a decreased systemic side effect profile for the patients.
So Char, tell me how you would send us the fentanyl.
The same way,
Okay,
in the
just draw one
syringes.
for us.
Mhm.
Okay,
Yep, yeah.
all right.
When it is nebulized, it has a localized effect on the chemoreceptors in the lung, and so it has a lower incidence of systemic side effects because it acts locally on those chemoreceptors. They also work to decrease the body's sensitivity to the increased levels of carbon dioxide in the blood, which in effect decreases the feeling of being short of breath. And then next up, perfect, is there's 3 other options that we sometimes use, not as commonly. And the most common is actually the mucolytics or the N-acetylcysteine, but more rarely the furosemide has been shown in some studies to decrease the sensation of breathlessness, alleviate tachypnea, and cause a reduction in cough without an increase in diuresis. And this is believed to be an action on a direct action on the pulmonary stretch receptors and irritant receptors in the lungs. Mucolytics like the N-acetylcysteine will sever the disulfide bonds in glycoproteins and essentially thin out the mucus. So it's obviously useful in patients with severe pulmonary secretions. It can cause bronchospasm, so it is recommended that if this agent is used, that it's used alongside a beta agonist along with it, and they can be combined together. And lastly is bupivacaine. It's a local anesthetic that acts in the respiratory tract. That has been shown to reduce exercise-induced bronchospasm, but also suppress chronic cough. I've never actually recommended this be used because it can cause a loss of the gag reflex for a period of time, and so it has to be administered in a really controlled setting. So you can't just have the family give it when a caregiver's not there. So, so in conclusion, we'll go ahead and next slide. Perfect. Dyspnea is a common and distressing symptom that's very common in hospice patients, and there's a lot of medications or a fair number of medications that can be nebulized, and they may be effective due to a local effect in the lungs and hence cause a decrease in systemic side effects. And it provides a good options to many patients that can't otherwise be effectively treated or would be at risk for systemic adverse effects, and also cost effective to the more expensive inhaler options that are out there. So are there any questions?
I have no experience with the inhaled opioids.
Mm-hmm.
So if you've got them on the patches and on everything else, if you're inhaling the opioids, what's your, overdose type of situation, or how much of that systemically are they having issues with the drowsiness? How much are they absorbing?
Sure, yeah, that's part of why we give them inhaled is if we're already giving opioids orally and we're still not achieving the benefit that we would like with the dyspnea and the shortness of breath and everything given orally, we can actually add on a nebulized medication and help enhance that treatment towards the dyspnea without increasing the overall risk for systemic side effects by very much.
Gotcha.
So, yeah, the answer to that is very minimal risk for increasing the, it helps mitigate those risks by giving it by
So the one
nebulization.
we're actually using, and I can share this with you because you're a pharmacist. So she's using the dexamethasone and 0.25 morphine together. And she does it PRN, but it totally calms her cough. So that cough that she was getting where she just get out of control, in fact, took her to the emergency room, she does that and it takes care of her cough. And so, yeah. And so she does it some days more often, but never has done it more than twice in a day, and it just, it makes a big difference for her, so.
Yeah, and any of these agents can be used alone or in combination with each other. Sometimes there's definitely an advantage to using more than one together.
Sure.
But yeah, like some patients will use just morphine alone, whereas others will use, the whole cocktail of.
You can make those up as a cocktail there and do.
We actually do them separately because they're stable for longer, as far as sterility goes and compatibility in the syringe. And so, yeah, you just put them all together at the time of administration.
Okay.
Are you using IV oral, or is there a special formulation for the med?
We use IV,
You use that?
Yeah,
IV?
and
So
then
like
it's
IV
inhaled.
Dex, just like we use it for oral and IV morphine, IV fentanyl.
Yes,
As well.
exactly.
Okay.
Yeah.
When I called Monica to get a report on JC last weekend,
Yeah.
she mentioned maybe nebulizing his morphine.
Mhm.
That
Gets
might
a
be
lot
a
of
good
side
idea
effects
for
from
him, huh?
Mhm.
So,
And do you just take, like, if, what the directions say for his oral and just do the same amount?
No,
in
it has
the
unique
nebulizer?
dosing. It has
Okay,
unique
so it'd have to
dosing,
be a
yeah.
whole separate,
Mhm.
So it works it.
yeah.
so if we were going to use, the morphine, nebulize the morphine for, like we would use the sublingual,
Mhm.
but use nebulize instead, tell us how to dose that.
So the morphine is dosed anywhere from, it's a 10 milligram per mil solution. And so it's dosed anywhere from 2.5 to 10, and can be titrated up or down if necessary. But normally we start with just 5 milligram dosing, unless there's other patient factors or whatever that suggest that maybe lower or higher is necessary. Current opioid dose can play effect into where you start them at. So if they're already on a really high dose of opioids and you aren't achieving that effect, and so obviously their tolerance is going to be higher, that type of thing, then you may want to start with a higher dose. But
Not for him.
Well,
if they're,
You got
yeah.
slowed on a quarter of a mil.
yeah, and
And
things
so,
like that. So
yeah.
if they're not
Just
much,
cut 'em
then
off
you
to
may just want to
2.5.
do 2.5 milligrams or something like that to start. So
How stable, so on those syringes, if you draw those up for us, how long can you hold on to those? Do I need to order, just a week's worth or?
28 days.
28 days is our max on,
yeah.
okay,
Yeah.
alright.
But if we get a vial, it's not that hard to drown off ourselves, right?
Yeah, but still.
It isn't, but
It does
once
sound
the vial's
right.
punctured, it's still recommended only 28 days
Cool.
from that time period.
Yeah,
So
it's filling.
Yeah, we did do that, and it wasn't that much fun.
it
I
wasn't
shouldn't
great.
We
speak,
would
I
rather
don't,
have you
I don't
do
ever
it.
draw vials, so
So,
that's all you guys.
He's like, I don't care, I'll make you do
Yeah.
it.
yeah, we would rather have you guys do it, because then they come in gold and everything else.
Yeah,
which is
yeah,
nice.
and they're all the same color,
And they're
obviously,
all-
because they're
yeah.
all clear, so it's easy to
So.
mix them up if somebody's
Yeah.
Yeah.
On a couple.
organized with things, so, which
Okay.
happens, so.
Perfect.
Store them refrigerated or no?
Huh?
Are they
Yes.
refrigerated?
Yeah.
Do you have normal dose range for the fentanyl?
Same general concept,
Mhm.
obviously it's 25 micrograms is the upper limit of that.
Mhm.
So, quarter to 1 mil of the 25 mic per mil.
25 mec per mil, so a quarter, so you're starting off somewhere around.
12.5 is usually what we do, 12.5 to 25
Okay.
is the most common doses for that, just because it's,
That's one I have never used.
I've never used it memorized.
Shame on Jared for not having used it.
Memorized.
Yeah, we use it pretty commonly, the fentanyl one, just
Mhm.
because, so, some clinicians are a little, I don't wanna take the risk with the bronchospasm, and there's really no cost difference associated with it, so why would we
So use
even
fentanyl
bother?
instead of morphine.
Whereas most people don't even experience that bronchospasm with morphine, so, 90 times out of 100, it's fine,
Mhm.
so, but yeah.
Is there any, fentanyl's typically shorter acting in IV form. Do you find that it's shorter acting in the nebulized form?
It
Or
is,
Morphine gives you a little more bang for your buck if you're.
it is a little shorter acting, yeah.
Okay.
Yeah, the morphine does tend to last a little bit longer than the fentanyl when it's nebulized too, so.
Cool.
It's kind of my go-to unless somebody has that problem, and then I say, well, let's just switch them to fentanyl,
Mhm.
so, yeah.
So you usually go for morphine first,
Mhm,
and then
I
if they
do.
do bronchospasm on you, change it up and go to fentanyl.
Mhm,
So
yeah.
easy.
so.
Great questions, thank you.
Yeah, really good questions.
Thanks for coming.
All
Alright.
right.
So we'll move on to pain management, opioid pain management. The steps of pain management, in my opinion, is really just a cycle of assessment, treatment, reassessment, dosing modification, so, treatment modification, and then assessment again, and just keeps going and going. It's a constantly changing condition that's affected by so many different things. And so really staying on top of that and continuing monitoring and making the changes that need to be made is important. Assessment often requires, identifying the etiology of the pain and conducting a thorough pain assessment are really critical. Do a H&P, a history and physical exam, and make sure you get the information for determining the type of pain, location, intensity, duration, frequency, aggravating and alleviating factors, the pain's effect on function and quality of life, and on patient goals and previous responses to treatment. So what have they been on before, and how did they respond to that? The types of pain are nociceptive, neuropathic, and functional pain. Nociceptive pain is divided into two groups, general groups, which is somatic and visceral. Nociceptive pain is physical damage to tissues, with visceral being to the internal organs and somatic being to like connective tissues or to like the skin, bone, muscles, that type of thing. And then neuropathic is damage to nerve fibers. So what's seen with diabetic neuropathy or postherpetic neuralgia. And then functional pain lastly is basically a broken nervous system or a malfunctioning nervous system like you see in fibromyalgia. Signs of pain are typical and non-typical. The typical signs of pain is verbalization of pain. They tell you they have pain. Facial expressions, tense muscles or guarding, or an increased blood pressure, heart rate, and respiratory rate. And then the non-typical signs such as unexplained agitation, disruptive behavior, restlessness, clutching, sobbing, or a labile mood. Some of these symptoms obviously occur with other disease states, which makes it very important to pay attention to them. But for instance, you have like a patient with Alzheimer's, and calling out or agitation is not an uncommon symptom with those, but sometimes you'll have an increase in those symptoms with those patients, and it's actually associated with pain, so kind of paying attention to that can be really key to helping effectively treat pain. And then the treatment. All patients with constant or nearly constant pain should be on a long-acting and a short-acting medication. The long-acting pain medication will minimize those peaks and troughs and help provide a constant level of pain relief, and should be titrated to allow no more than 2 to 3 breakthrough doses of a short-acting pain reliever in a day. And there's no maximum dose of an opioid, so it can be titrated until analgesia is achieved, or until side effects limit a further increase in the dose. The typical duration of a long-acting pain medications are usually around 8 to 12 hours, so they're dosed 2 to 3 times a day. The short-acting pain medications, the dose of those should be set at 10 to 15% of the total daily dose. So for instance, if you have a patient that's on morphine 30 milligrams 3 times a day, their total daily dose of morphine is 90. So you'll want a breakthrough dose that's at 10 to 15 milligrams of morphine every 4 hours as needed. You can dose the short-acting up to every hour in those critical situations where you're trying to get on top of the pain, or at you'll see at the very end of life where you have a sudden increase in the need for that. The short-acting pain medication should be used alone only initially in order to establish a total daily dose that's required to achieve a good analgesia, and then the long-acting pain medication should be added in and calculated based off of that total daily dose. It's good to keep in mind to not play catch-up. So if an analgesic effect is not achieved by the time the agent reaches its peak effect, give another dose. Don't see how long they can last before you give another one. Get it under control. Otherwise, you actually end up giving a higher overall opioid dose than you would if you maintained with a good level of control. And you really shouldn't use more than 2 opioids in the same class. simultaneously unless it's for that short and long-acting agent. Sorry, mouth's a little dry. Only because with the short-acting, you can titrate up to a maximum dose until you achieve that effect, or you reach the side effects. And they're the same mechanism of action with all of the agents, so there's really no need to add, have the long-acting morphine plus, thank you very much, and then have oxycodone and hydromorphone and morphine for short-acting all on board. And I've seen a fair number of patients that are on those kind of regimens. And so I always recommend to kind of consolidate that. It's less likely to cause med errors and to give a better overall control. And so if you end up with a patient that you've kind of maximized out and they still aren't under good pain control, then I recommend that you add other adjuvant options other than non-opioid options to the regimen. And also in those difficult to treat patients, consider sub-Q or IV administration with a CAD pump for those patients. And I have included infusion resources in the back of there that kind of gives a little more information than we'll go over today, but just for your reference.
So do you do the infusion stuff?
We do.
So, and can you get it to me the next day?
Yes, we can.
And so, because that's our biggest problem with doing anything infusion-wise is
Is access.
access.
Yeah, we can send them next day.
I just don't have access. So,
Do you have a pump?
do we have a pump?
We send those too.
Do you have a pump?
We
Yeah.
actually brought one to take a look at once we're done
Yeah,
with everything. We
Yeah,
can-
that and some
So-
supplies and everything.
there,
if anybody
yeah.
wants to take a look, and I can go over it with anybody who's
Okay.
interested too.
And it's just sub-Q, isn't it?
Sub-Q or IV, yeah, they can be administered
Either way.
in a variety of ways, yeah. I mean, normally, like in a patient's home, you do sub-Q unless they already have a port or something, so.
Price-wise, what are we looking at?
I can send over a pricing list sheet of the different, because there's several agents and, there's different size cassettes and things like that, so there's a little pricing variation, but yeah, I can send that over if you're interested in it, for sure. Yeah. So,
Cause our go-to kind of patches,
Hmm?
our go-to kind of patches, just because we don't have
Yep.
access to.
And that's the reason why we use
Pump
it,
system.
yeah.
yeah.
Well, not only that, but the patch is much easier to manage. I don't, we typically don't have any patch issues. Pumps tend to have.
Far away, you don't want to drive out to Haynes Creek every
Right.
other day to.
So,
Injects it.
well, and patients, with a patch, you slap it on and then they don't worry about it, they don't think about it because they don't see it. Pump, sometimes, it's just kind of pain for them. However, those that are really bad, that we're really struggling to do it and they're getting
Yeah.
close.
Yeah. It offers a lot of,
They're probably gonna need something.
Yeah.
Yeah.
it offers a lot of fluctuation in the dosing and the ability to titrate very quickly.
You can sub,
Um,
you can sub-Q.
I would think the
Cause
pump
IV.
is gonna be better than the patch, even sub-Q.
What's that, sorry?
Is a sub-Q pump gonna be more effective than a patch?
It
You're
will.
not familiar with IV.
It kind of depends on the situation,
Okay.
obviously,
Okay.
but yeah, sub-Q and IV are actually very similar.
Okay.
Uh-huh. Yeah, they're dosed exactly the same, so.
So I'm thinking like, at some point, maybe Nikki?
Can you
already-
bolus sub-Q?
You can.
Okay.
Yeah, we do a continuous anabolus dosing on them, yeah. So,
Make sure, cause if you've got somebody on those really long acting agents, you can taper them up then with the pump, then the way you would need to make sure that we're not.
yep,
Right.
yeah. Especially with the rapidly changing, symptoms and the patient's condition, so, yeah. With opioid pain management, monitoring is essentially the key to effective and safe pain management and risk mitigation. Do a periodic HNP, reassess the patient's pain and the effectiveness of the current regimen, as well as monitor for side effects. Common side effects include dizziness, somnolence, nausea, vomiting, dysphoria, euphoria, itching, and respiratory depression, as well as constipation. Tolerance does develop to all of these side effects with prolonged therapy or prolonged treatment, except for constipation, which is why we have to, you know, give prophylactic treatment for constipation, do a bowel regimen in all patients taking opioids chronically. Their side effects can be useful to treat other conditions as well, obviously, like shortness of breath, cough, anxiety, and diarrhea. When a dosage adjustment is deemed necessary, so you know, have that patient, you've set them up on initial treatment based off of the, you know, all the patient factors, and then they have an increase in pain, so you need to make a dose adjustment. Calculate the increase in the long-acting agent based off of their short-acting utilization. This isn't always possible because sometimes people don't log it, you know, they poor historians. So you can use kind of the rule of thumb to increase the dose by 25 to 50% in mild to moderate pain, or 50 to 100% with moderate to severe. Again, it's preferred to you know, to base your calculations off of actual utilization, however. When you're converting to one agent to another, so they're not doing well on one, or, you know, say they were on long-acting morphine and now you need to switch to a patch or something like that, decrease the dose by 25 to 50%. In one instance where you might not want to do this is if you actually are changing to another agent, but the pain is already not controlled. You wouldn't necessarily want a dose decrease. But conversion resources, so when you're switching from one agent to another, there's lots of ecoanalgesic charts out there, and there is some good opioid calculators, conversion calculators out there. My favorite is actually globalrph.com, and then the opioid converter advanced. It does methadone very well, which is not that common. There's some calculators out there for that, but I wouldn't trust. But that one actually does it quite well. And then, of course, you can call me. I'm always there. I do calculations all day for this type of thing. And then our other full-time pharmacist, Catherine's also very skilled in pain management as well.
And that global RH is also a warfarin
Mm-hmm.
calculator.
Yeah. Mm-hmm.
What are you saying? I should purchase that and do
No, it's free.
Free.
Yeah, it is. It's free. So, and they're a good resource.
Just put in protocol, yeah.
Right.
There are two opioid calculators on there, and one of them is not that great. You want to use the one that says advanced on it, if you're gonna be using it.
Okay.
So the common opioid analgesics, I'm sure you're all, you know, familiar with them. I'll just go over a few little things. The morphine, immediate release and extended release available. There are capsules available that are 24-hour release. They're really expensive, and really the only advantage they offer is once a day dosing over the tablets,
It's
which
not an
are
option, so.
2 to 3 times a day. Right.
I understand, it's not an option.
That's it, yeah. And then the immediate release formulations, both tablets and liquid. The liquid offers, you know, a variety of dosing availability there, so you can do a teeny weeny dose for somebody who doesn't need very much, or, you know, larger doses and still have a small volume with the 20 milligrams per mil. Metabolites can accumulate in kidney disease with morphine, so you might want to consider hydromorphone or oxycodone if higher doses are required in those patients. Codeine, acetaminophen, hydrocodone, acetaminophen, 2 other agents. Hydromorphone has immediate release and extended release. Again, don't use the extended release, it's expensive, known as Exalgo. And then there's oxycodone, immediate release and extended release. The OxyContin is fairly expensive, but obviously not as bad as the 24-hour morphine or the extended release hydromorphone. The combination products, like the oxycodone, oxycodone, acetaminophen, oxycodone, aspirin. They're actually not as cost effective as using those agents separately. So if you have just immediate release oxycodone and then add Tylenol separately, it's, you know, a lot cheaper to do it that way.
Can I use Oxycontin?
Can you just use oxycodone? Yeah, you really have to.
Oh, just looking
No,
at, or told you.
but I don't think you should use it.
Well, yeah. I got pain.
Maybe after that race.
It hurts.
This
Right.
weekend you might need it. Yeah, we haven't had, a lot of patients have been on it because of that.
Yeah.
They haven't come to us with that, so, cause it has been pricey.
Well,
And a lot of the insurances, some of the insurances won't even cover it
Yeah.
for
Who am
them.
I thinking of? I'm thinking of our guy with the toes that's trying to get his
Oh,
pre-albumin up,
yeah,
because he's on like 6 of the
hospitals.
oxycodones
Yep.
today.
Mm.
And we tried to switch him to morphine, but he didn't tolerate the morphine.
Yeah, so that's
Trying to get him on
what
a
we do.
long-acting, very long-acting.
Okay.
Might be
Which would be
enough.
better because they're not dosing it very
I
well.
don't think we're testing them well,
No.
no. And that's what I worry about. And I also worry about short-actings in that house.
Got it.
Mm.
Yep, okay.
So next is the fentanyl, which we were talking about earlier, which has the ease of use advantage. You know, slap on a patch, change it over 3 days. It also has a unique dosage conversion, which has a high incidence of calculation errors, and so experts only doing conversions to or from fentanyl, mostly because it's a microgram, the others are milligrams, and it's a microgram per hour versus total dose, and so it tends to confuse people when they're trying to do calculations, or they'll miss a step or something like that. So make sure that you utilize pain management clinician or pharmacist or that type of thing. And it is a fairly cost-effective option for patients that maybe don't tolerate morphine or that type of thing. Couple things to keep in mind: the 12 microgram patch is more expensive
Twice
than
as expensive
the
as
25, 50, 75, or 100 microgram patches.
Isn't that crazy?
And don't even think about using the 37.5, 67.5, or 87.5 doses. They're astronomically expensive comparatively. You're better off using 2 or even 3 patches than using one of those. So,
So,
cost-wise.
on the fentanyl patch,
Mhm.
do you just titrate the patient comfort? I mean, is there a max that you should be given? So you can just indefinitely?
You just want to be really careful, obviously, with starting doses, because it's not a medication you want to give to an opioid naive patient. But yeah, if they're already established, there's no.
Alright.
Yeah, I've seen patients on like 400 micrograms.
Okay.
So you gotta remove
800.
Not much.
I had a gal on 800 and she
Wow.
took a 1 ml of
Morphine.
Roxanol every single hour, and she's still talking and walking.
Yeah,
And she's 800.
yeah,
It's very,
yeah,
Yeah.
huge
Yeah.
doses.
Oh, really?
A few years ago.
Yeah.
Yeah. One of Dixon's patients. Of course. So, yeah, and she was still walking, talking. Like, ooh.
Yeah, some pretty high opioid doses.
Yeah.
Next one's methadone. I've also included some methadone resources at the back, a whole separate handout and everything if you have questions. It's a great reference tool for dosing and things like that. It's an extremely cost-effective option for long-acting pain relief. I personally like it. It does really well in cancer pain, and it has a multimodal action to treat both physical pain as well as neuropathic pain. And so it's great in patients with a high level of neuropathic pain as well as other pain syndromes going on. It's the only available liquid long-acting medication, and its long-acting properties actually come from the drug itself rather than the formulation, like most opioids are. It's a highly lipophilic drug, so it essentially is deposited into the fatty tissues of the patient and then released over time from those fat deposits. So that impacts the way it's dosed. So if you have a person that's moderate to overweight, they're going to be dosed twice a day versus somebody who's really skinny. You'll want to dose them 3 times a day because they have less fat stores to accumulate drug into. You will, because of this effect, it takes a longer time to reach its peak effect than other drugs, so it can take up to 5 or even 7 days to reach peak effect. So you'll want to overlap the current opioid that you're on when you start a medication, so that you don't leave them in excessive pain or even trigger a pain crisis. So, monitoring, yes, it is a high-risk medication, but with appropriate treatment and monitoring, it can be used safely and effectively. And daily monitoring upon initiation is essential. You can employ the family, or you will want to employ the family with monitoring. We send home a bag stuffer with all of our methadone prescriptions that basically list out what to look for the family. You know, if you see any changes in this, this, and this, you know, report it back to your hospice agency, and that helps too. And then also just the education on the side effects, educating the family on, you know, kind of the uniqueness of this drug. Dosing considerations, sort of like fentanyl, it has unique dosing considerations just because of its lipophilicity. You have to dose it differently, and, you know, the overlap and that type of thing. And so, and it doesn't, I'm not explaining that well. It doesn't have a normal curve like other drugs do. So basically, the higher the opioid tolerance it is, the more methadone you give. So if somebody, for instance, is on just 10 milligrams of morphine a day, then you're going to start them off on a little dose. But if they're on 800 milligrams of morphine a day, it's not going to go up exponentially for the methadone dose. You're still just going to start with 30 milligrams of methadone a day as a max. So always calculate initial doses and dose increases using a reliable calculator, or utilizing your pain management pharmacist or clinician or whatever. Never start a patient on greater than 30 milligrams a day, and never increase by more than 30 milligrams a day. And wait 5 to 7 days after any dose change before reevaluating that dose and making another change. And lastly of the opioids is tramadol. It's actually an opioid-like medication. It's available in immediate and extended release. It can be a good option in some patients that have mild to moderate chronic pain, that don't yet, you know, require a full opioid agonist. It can lower the seizure threshold, and it does need to be dose adjusted in liver and kidney disease, so it may not be a good candidate in patients with those risks.
How expensive is the ER now?
It's pretty cheap.
Oh, it's pretty cheap.
Mm-hmm. Yeah, it's not bad. It's generic now, so it's not that bad.
It's like, oh.
It's maybe not. Yeah. And then other non-opioid and adjuvant options. So when you need to add another agent on, first on the list is Tylenol. It can heighten the effectiveness of opioids when given concomitantly. Caution with liver disease and heavy alcohol users, it's recommended that you avoid them in those cases. Never give more than 4,000 milligrams in a day or 3,000 milligrams in a day in the elderly. NSAIDs such as aspirin, naproxen, ibuprofen, ketorolac, anti-inflammatories, they do carry a risk for GI bleed and kidney damage. You can mitigate that risk for the GI bleed with the PPI, and so I always recommend if you have somebody that's on, you know, an NSAID chronically, that you start a PPI in order to help, you know, reduce that risk. There's a ceiling effect with NSAIDs, so giving a higher and higher dose doesn't necessarily mean that you will achieve more pain relief. Duloxetine, Cymbalta can be good with neuropathic pain. There's several agents, gabapentin, carbamazepine, Lyrica, to name a few, that are are good for neuropathic pain. Sorry, the duloxetine was for functional pain. I think I said neuropathic. It's good for fibromyalgia. Ketamine is a product that we compound in our pharmacy that can be very useful in patients where you're at your wit's end and you have a patient that is a pain patient that's got a complicated case, intractable pain, you just don't know what else to do. You can use this medication, and I've had really good success with it. However, it does have an extensive side effect profile because it affects so many different receptors and impacts so many different neurotransmitters and so forth. The biggest side effect is hallucinations and psychotic behavior, psychotic, symptoms. And so much so that it's recommended that you pre-treat to avoid those symptoms with an antipsychotic, at least for the first 5 to 7 days, and then reevaluate whether it's needed or not.
What do you guys typically use for your antipsychotic for that?
We use Haldol usually, just because of cost and the ease of use. But yeah, you can use risperidone or Zyprexa as well.
Can you mix with your pump? Can you get ketamine plus a narcotic pain medication? Seriously, I mean, we do it in the ICU all the time on PCAs.
Yeah.
We actually more often use, in the hospice setting, use ketamine orally.
Right.
Yeah, because
But if they can still swallow pills, ketamine's gonna be pretty.
well, it's liquid. We compound a liquid that's similar in concentration to the lorazepam or the morphine, that type of thing, to where you just have to use a low volume sublingually. But you can administer IV, obviously, and you can combine it. So.
Yeah, they're using it for pain control PCAs.
Mhm.
Like, a lot.
Mhm.
And that's in the last few years, really.
Yeah.
Otherwise, it was just for sedation.
Mhm.
Yeah.
Lastly, lots of topical preparations, creams, ointments, patches, all kinds. There's lots of over-the-counter formulations, Salon Pause, Asper Cream, Icy Hot. Then there's also like Voltaren with NSAID. The lidocaine patches, there is a 4% strength that's available over the counter, and it is a lot cheaper than the 5% prescription strength. So something to keep in mind.
Yeah.
Sacrifice a little bit, but you get, a lot more bang for the buck, so to speak. Then there's steroids, prednisone, dexamethasone, great for severe bone pain or significant inflammatory pain. Again, carry the risk for GI bleed, use a PPI when necessary. And then there's also various compounded preparations that can be used in unique situations, such as morphine gel. If you have an open wound, it can be sprayed on it. There's methadone cream, used very rarely, but sometimes you have a really agitated patient. We've used methadone cream in those patients that won't take anything. There's lidocaine gabapentin cream for some neuropathies and stuff like that we can utilize. Lots more, but
Sure, so, so with those, the morphine, the spray, tell me a little bit about that for our open wounds. I mean, we've got a couple patients that are just horrendous feet, really bad diabetic ulcers.
yeah, so we just compounded gel, and so it can be applied to just basically, it's a 10 milligram per mil gel, and you just get a little spray bottle and they spray it over the top of the wound, or you can apply it just,
Okay.
topically around the area, or, apply it to the gauze when you do dressing change or anything like that, yeah. There's a variety of ways that people have found that it, they've been able to
And fairly
utilize it, but,
inexpensive.
yeah.
Works-
Similar to the ABHR pricing.
Okay, does it work
Yeah.
better than like the lidocaine?
It does, it just works differently, and so, and you can use both even,
Use it together.
Mhm.
Okay.
What strength is it being compounded in
10 milligrams per mil.
per mil? Okay.
Mhm.
And so is it like, are you are there parameters for the providers that how much they should be putting on?
Not really,
Put on
because
one,
because the most common use is, you know,
yeah.
yeah, and so not really. It's just, you know, a sufficient amount to, you know, sparingly cover the
Cover the
wound
wound.
bed.
Okay.
But yeah,
Do you make
not really.
stronger? Do you make like 20 of them?
We
20
haven't.
milligrams from those, or-
yeah, we've just done the 10,
Okay.
just kind
Just
of
out of
standardized
curiosity.
it. But yeah,
Kinda curious. Yeah.
yeah.
Is there like a, like if you spray it, like use every 4, or is it just kinda like as?
Usually with wound change or with dressing changes.
Just dressing
Mhm.
changes?
You can use it more frequently. I usually recommend like every 4 hours as needed and with dressing changes. But
And then do you have to wait like a certain amount of time before it takes effect and you do the dressing change?
I would recommend waiting like 15 minutes or so just to make sure that you have, you know, effect with the morphine. But yeah.
And then, type of the for neuropathy, because again, we got a couple patients that neuropathy is really, their legs are really bad, whether it's diabetic or whatever. Tell me about pain management topically for them.
Yeah, so I forget the concentrations on that we do on the lidocaine and gabapentin typically. I believe it's pretty high actually. It's like 10 and 30%, I think. But essentially, you're just taking the lidocaine, which is commonly applied topically, increasing the concentration of it significantly, and then using gabapentin also taken orally for neuropathic pain, and then applying it topically. There isn't a lot of, you know, evidence out there for its use, other than anecdotal reports that, you know,
It seemed to work.
the patients have reported that it's worked quite well. So maybe worth a try on occasion for those particular
Who?
patients.
Gabapentin orally, like for your patients, your hospice patients? I mean, I don't see.
We do. We don't have a ton on, but we do have.
Yeah, but it's helped.
Yeah, we do have some, but we don't
I
have
found some
some.
good stuff with it. I just never, you know.
And it's getting used as an adjunct a lot too in the hospital.
Yeah.
For pain medications.
I've seen it even. I got some surgeons that use it post-surgically.
Yeah, exactly.
Huge.
Cardiac surgeons started doing that as well.
Yeah.
Yeah.
Okay.
So in summary, application of the fundamental principles of pain management can result in the safest and most effective outcomes possible. Conduct a thorough pain assessment. Use a long and a short-acting agent for chronic pain. Employ family and caregivers to assist with the monitoring, and conduct frequent assessments and modify treatment regimen accordingly. Remember to acquire accurate calculations and consider other contributing factors when doing any dosing adjustments or from switching from one agent to another. Essentially, pain management is a continual cycle of treatment or assessment, treatment, an ongoing process. So, all right. Well, that's it for me. What other questions do you guys have on that?
So yeah, so you're welcome to hang out. Chart and Faith said they would hang out for the afternoon or whatever.
Yeah.
We don't care if they have to.
At your disposal. That's what I'm here for.
So yeah. So any questions that you might have or whatever, this is the time to do that. And it can be very informal. So thank you.
Yeah, you're
I
welcome.
appreciate it. So.